Okay. So question 1. A 38-year-old woman presents with an 8-week history of symmetrical joint pain and swelling involving the metatarsopharyngeal, and proximal interphalangeal joints. Symptoms are worse in the morning and last more than 1 hour. Choice A, what is the most likely diagnosis? Choice B, outline 3 risk factors associated with this disease. Choice C, outline 4 extra-articular manifestations of this disease. So A is rheumatoid arthritis. Very good. Okay. Outline 3 risk factors associated with this disease. What are the risk factors of rheumatoid arthritis? Genetic predisposition, good. So HLA-DR4 and HLA-DR1, yes. So how I used to remember is you say HLA-DR4. So 4 is from the word rheumatoid arthritis. So a room has, you can imagine like a 4-bedroom house or a 4-roomed house. So that's how you remember. So genetic predisposition, yes. Family history of autoimmune diseases. Okay. So if your parent had rheumatoid arthritis, you are most likely going to get it. Smoking, yes. Smoking. Female, old age. So being female is a risk factor. Old age, so age, yes. Female gender, yes. So male, no, it's actually female. Any other risk factor you can think of? So here we have them. So genetic predisposition, tobacco smoking, female, obesity, and family history of rheumatoid arthritis. Good. And then outline 4 extra-articular manifestations of the disease. When I mean extra-articular, when I say extra-articular, I mean manifestations of the disease that occur outside of the joints, basically. So we have already been told joint pain that is lasting more than 1 hour. And then we have already been told joint swelling. So can I get other manifestations of the disease? So we can be systematic. We can start from CNS, we go to CVS, we go to GIT, we go to renal, we go to, it also affects the eyes. So ocular manifestations, okay? So let me see your answers. I'm seeing someone is asking history of strep throat. So I think you're confusing. These are 2 different diseases. There's rheumatoid arthritis and there's rheumatic fever. Okay? So what you're saying is rheumatic fever. Okay? Rheumatoid arthritis is an autoimmune disease, and rheumatic fever is a disease caused by a bacteria that can go and affect the heart. That is the sequel, okay? It causes rheumatic heart disease. So we're talking about rheumatoid arthritis. This is a joint disease. Okay, extra-articular manifestations. So scleritis and episcleritis, good. So ocular manifestations of rheumatoid arthritis, scleritis, which means inflammation of the sclera. And then we have, someone has mentioned keratoconjunctivitis sicca, basically dry eyes, yes. Okay, then we have RESP, it causes interstitial lung disease, yes, that is under RESP. Skin, rheumatoid nodules, yes. neuropathies. Yes, so you've already mentioned the 4, but you can go through them. So if you were asked articular manifestations, these are the joint ones. We have cervical subluxation. Okay, so subluxation is not really a fracture, it's like a mild fracture. Okay, then ulnar finger deviation. So when you're seeing the joints of these patients, the finger, the last 2 fingers will point medially. Okay, that is the ulnar finger deviation. Then swan neck deformity. Swan neck deformity, the joint looks like a swan. Okay, normally there is, at the PIP, it usually hyperextends and the DIP flexes. And then we have botonier deformity. Here, what happens? The PIP flex and the DIP hyperextends. Okay. Then ocular, as we had said, keratoconjunctivitis, SICA, the dry eyes. This is due to secondary Sjogren's syndrome, characterized by dry eyes and mouth. So we know Sjogren's syndrome, it's one of the diseases that comes with rheumatoid arthritis. You know, it's an autoimmune disease. And Sjogren's syndrome is characterized by dry secretions. So you'll have dry mouth, you'll have inability to produce sweat or tears, and then even you'll have itchiness, especially in women, itchy vaginas, because you have dry secretions. You're not able to secrete vaginal fluids, okay? And then we have scleritis, uveitis. So one thing I want you guys to know from this session is, if you have a question on any autoimmune disease, that is, if it's SLE, rheumatoid arthritis, any autoimmune disease, you have to have uveitis. Okay, the uvea is never spared. The uvea is almost all the time affected. Okay, then scleromalacia performance, severe painless thinning of the sclera. Then for pulmonary, as someone had said, interstitial lung disease, including rheumatoid pneumonitis and fibrosis. You also have pleuritis, pleural effusions, and then rheumatoid nodules in the lungs. So since you've been told manifestations, if you mention this, you have to give the symptoms. So you'll say, if it's a cough, if you're having chest pain, okay, difficulty in breathing. And then CVS, we have pericarditis, which can lead to pericardial effusion. And then we have rheumatoid vasculitis, damage to the blood vessels leading to ischemia and tissue damage. For dermatology, rheumatoid nodules, subcutaneous nodules found over bony prominences or extensor surfaces. Neurological, peripheral neuropathy. So they'll tell you, I'm feeling tingling, numbness, okay, on their legs. Hematologic, anemia of chronic disease. Any inflammatory process, we expect anemia of chronic disease. And then we have something called Felty syndrome, characterized by a triad of rheumatoid arthritis, splenomegaly, and neutropenia. So in this patient, they usually have recurrent infections and splenomegaly. Then GIT, I tried looking, but rheumatoid arthritis doesn't really affect the GIT. But, you know, in these patients, because they're usually in chronic pain, they usually take NSAIDs for a very long time. So what happens is they'll develop gastrointestinal bleeding. Okay, we know NSAIDs usually cause GIT bleeding. Okay, so this is a potential, remember it came in our MCQs end of year. You're given a patient who is taking rheumatoid arthritis, who has rheumatoid arthritis and they're taking NSAIDs. Then you're told what are they at greatest risk for. So it's usually GIT bleeding, okay? And this bleeding can also cause perforation of the ulcers. So they usually have ulcers, peptic ulcer diseases, and then it can also cause perforation or hemorrhage. Then we have renal amyloidosis, similar to the Sjogren's syndrome. Here we have amyloids that deposit on the nephrons, secondary to chronic inflammation, leading to proteinuria and renal dysfunction. And then since they're taking NSAIDs, you can have drug-induced nephropathy. Then constitutional symptoms, fatigue, fever, weight loss, and then musculoskeletal carpal tunnel syndrome. So in this question, you won't be able, you won't, you will, it's not you won't. You'll be able to mention at least 5 or 6, but you have to be very systematic. If you go system by system, trust me, you'll find yourself mentioning a lot of points. Okay? Any question on this? So go check on that. So one thing I want to mention, people usually confuse the difference between rheumatoid arthritis and osteoarthritis. So one, rheumatoid arthritis is an autoimmune disease, okay? And osteoarthritis is a mechanical wear and tear disease. What does that mean? The more you use a joint, the more it becomes worn out. Basically, think of this. You're having a joint, let's say the knee joint. The more you use it, when you're using the knee joint to walk, the surfaces are rubbing against each other. So the more you use it, the more it becomes worn out. Then inflammation occurs and the disease, and what happens is they usually change of collagen from type 2 to type 1, okay? For rheumatoid arthritis, it's an autoimmune disorder. So there's no inflammation that will occur. It's just that antibodies against, rheumatoid factor antibodies will go damage the joints, okay? Predisposing factors, they usually share being female, being obese, okay? Then for osteoarthritis, most likely we have age. The older you are, the more likely you're going to get osteoarthritis because you're using your joint for a long period of time. And then if you have joint trauma, it predisposes you to osteoarthritis. But for rheumatoid arthritis, as we had said, the main ones, genetic, tobacco, female, obesity, and family history. And then the 2 tests we do for rheumatoid arthritis antibodies, we look for rheumatoid factor antibodies and anti-CCP antibodies, okay? It's called anticyclic citrullinated peptide antibodies, which is more specific. Then another difference is, as you can see here, symptoms are worse in the morning and last more than 1 hour. In osteoarthritic patients, they'll tell you their symptoms don't last more than 1 hour, okay? So they'll have stiff joints, but they last less than 1 hour, okay? And then for patients with rheumatoid arthritis, the more they use the joint, the better it becomes, okay? How I understood this is someone who their joint inflammation is occurring at the joint due to antibodies. So if they don't use that joint, they're going to feel pain and it's going to become stiff, okay? But for osteoarthritis, these are people who they have used this joint such that the more they continue using it, it gets worse. So symptoms are relieved by rest in an osteoarthritic patient, but in rheumatoid arthritis, the symptoms are relieved by using the joint or with use of the joint, okay? Understood that? And then another difference is symmetrical joint pain, okay? Left leg, right leg, similar. But for osteoarthritis, it depends which joint has been really affected. It can be the right knee or the left hip. You understand? So osteoarthritis is more asymmetrical. But rheumatoid arthritis, you have symmetrical joint pain. Okay? Yes, and osteoarthritis is more of a orthopedic case, and rheumatoid arthritis is more of an internal medicine case because it's an autoimmune disease. Okay? I hope I've shed some light on the differences because that is something you should know. Okay. Question 2. A 14-year-old boy presents with a 3-day history of continuous knuckle headaches accompanied by photophobia, fever, and vomiting. On examination, he is sick-looking, irritable, and febrile at 39 degrees Celsius. BP is 95/60, heart rate is 100 beats per minute, and the rest rate is 18 breaths per minute. The neck is stiff, and Cunning's and Brudinsky sign are positive. Fundoscopic examination shows no papilledema. there are no other focal neurological signs. What is the most likely diagnosis? And give 3 reasons to support it. Okay, answers. Okay, I'm seeing everyone has got it correct. Meningitis, yes. So if you are to give the reasons, positive Canning sign, positive Brzezinski, photophobia, neck stiffness, headache, okay? The triad, have we got the triad? The classical triad for meningitis. So there's meningismus and there's meningitis. Those are different things. Meningitis basically means inflammation of the meninges. Okay. For meningismus, the triad is usually headache, which it is there, neck stiffness, which is there, and photophobia, which is there. So the patient has meningismus. And then they have a fever, 39 degrees Celsius. And then do they have altered mental status, or basically are they confused? We know that they are not, because there are no other focal neurological signs. But from what I've explained, you've already got your 3 reasons. Okay, good. Why is the absence of papilledema on fundoscopy significant in this case? And then C, identify the risk factors associated with the above disease. Which 2 most common bacteria are responsible for the above presentation in this boy? So the boy is 14 years old. After CSF fluid analysis, it was established the causal organism was bacterial. Outline the CSF fluid findings expected. Okay, good. So answers in the chat. Oh yes, I forgot to add a question. So on that question, you can add what diagnostic tests or laboratory tests would you do to assess this patient? Okay, so add that. Sorry, I forgot to add it here, but that was one of the questions. So why is the absence of papilledema on fundoscopy significant in this case? So I've seen someone has said it. Fundoscopy to rule out increased ICP as a cause of the headache and vomiting. Papilledema will signify an increased intracranial pressure, hence ruling out LP for diagnosis. Good. So I think you get the picture. So normally, before we do a lumbar puncture, you have to check features of increased intracranial pressure. You cannot. A lumbar puncture is contraindicated in a patient who has features of increased intracranial pressure. Okay. So in our case, the fundoscopy showed no papilledema, and we know papilledema is one of the features of increased intracranial pressure. So there was no evidence of raised intracranial pressure. So an LP would have been good to do, okay, or safe. And then identify the risk factors associated with the above disease. I've seen quite a few. I've seen quite a few here on the chart. Immunocompromised. So yes, if you're in an immunocompromised state, these are patients who have HIV, taking chemotherapy drugs, crowded living conditions, because we know that this disease can be spread by aerosol route. So if you're living in crowded areas, for example, dormitories, military barracks, it's going to be easy to spread the disease. Then contact with infected person. So if you have an infected person who has meningitis, you can easily get it. Age, we know that the elderly and the very young can get the disease. So yes, there are quite a few risk factors. And then what are the 2 most common bacteria responsible for the above presentation in this boy? I've seen someone say strep pneumoniae and Neisseria meningitis. Good. And then the tests before we do the CSF analysis. So complete blood count, yes. Markers of inflammation, raised ESR, CRP, yes. And then an LP, you'll also do an LP because you've rolled out features of increased ICP. Okay. And then for the CSF fluid analysis, we know that it is bacterial. So on CSF fluid analysis, we start with on inspection. What will you see on inspection of the CSF after collecting it? Turbid or cloudy. Very good. Then we go to glucose. What do you expect to see on glucose? It will be decreased because the bacteria is using the glucose for metabolism. Okay, good. Elevated protein. Yes, it will be elevated. Neutrophils. So the primary cell or the predominant cell will be neutrophils because it is bacterial in nature. Increased lymphocyte count is for viral. Yes. Okay. So we had said meningitis, evidence, the headaches accompanied by photophobia, fever, vomiting, neck stiffness, positive, and Rudinsky and Koenig sign. Absence of papilledema on fundoscopy suggests no evidence of raised intracranial pressure, making the lumbar puncture safe. For the risk factors, there are quite a lot. Age on both ends of the spectrum, infants and older adults, living condition, close contact and crowded environments like the military barracks, immunocompromised, HIV, chemotherapy, immunosuppressive drugs, high risk of meningitis, vaccination status. Do you know there are vaccines for not Neisseria, Streptococcus, meningococcus? Yes, there's vaccines for Neisseria meningitis, meningococcus vaccines, and strep pneumonia, pneumococcus. So unvaccinated people are more likely to get meningitis than unvaccinated. So this is something you should be ruling out in the history. I hope you guys usually ask. Okay. And then we go to infection, prior or concurrent infections, an upper resp infection, sinus infection, otitis media, or pneumonia. This is because if you have a concurrent infection, the bacteria, virus, fungus, can spread and enter and penetrate till the meninges. And then head trauma, head injuries, skull fractures or head trauma can provide a pathway for bacteria to enter the meninges. Recent neurosurgery, surgery involving the brain or spinal cord can increase the risk of infection leading to meningitis. So this can be, you can imagine you're doing a neurosurgery. So you have a neurosurgery session and then your material or tools are infected with this bacteria. Basically, they're not sterile, so you can increase the risk of getting meningitis. Occupational, people working in the healthcare or lab settings at an increased risk. So like us, that's why we get these vaccines occasionally. Then smoking and alcohol abuse. Okay, so usually asked like 3, I've mentioned almost 10. So you won't be able, you'd be able to mention a few. Then 2 most common bacteria, Neisseria meningitis and strep pneumoniae. What if the child was, let's say 2 weeks old? What is the most common bacteria? If the child were 2 weeks old? E. coli and group B strep. Good. Strep galactiae. Those are the 2 most common. Okay. After CSF fluid analysis, so I have a table here. So bacterial meningitis. Appearance, turbid or cloudy. White blood cells, the normal is 0 to 5, for them greater than 1,000. Then it's predominantly neutrophils. Protein, normal is 15 to 45. This one will show elevated. Glucose to be low because, as I had said, the bacteria is using it for metabolism. CSF serum, stroke serum glucose ratio. So if you are to reason this out, in the CSF, we are going to have a lot of glucose. In the serum, we'll have, if you are to compare, where will we have more glucose? In the CSF or in the serum? Where do you expect to have more glucose? In the serum, isn't it? So for these people, their ratio is going to be less than 0.4. So assuming if you were to do the math, the CSF, okay, I don't know normal glucose in CSF, unless I check the values. Maybe someone can be checking for us. We do the normal values for CSF and for serum, and then we try and calculate and predict, try and predict. Then lactate levels, theirs is usually elevated. And then opening pressure, usually elevated. So you'd be asked, so this question today was bacterial. Tomorrow it can be viral. The next day it can be TB. It can be fungal. Okay. So basically, if you ask this question, you start with on inspection, it will be cloudy. Then opening pressure, because in all the meningitis, the opening pressure is usually elevated. They don't really want you to mention these values. If you just mention increased, decreased, that is fine by them. And then you go to protein, elevated, glucose will be low, lactate will be high, white blood cells will be high, predominantly neutrophils. That's enough. The values are not that important. But if you just mention elevated or decreased, that would be okay. So I hope someone is checking for us. Normal serum and CSF glucose so that you can try and work out these maths. In the meantime, we can go to the next question. So the next question is on ethics. During our time, by the way, something to mention is you're going to do exam in around 7 or 8 batches or groups. So each day the viva will be different. Okay. So on day 1, maybe it will be a CVS viva and an ethics viva. Day 2, RESP viva, GIT viva, like that. So you should be revising all these topics. Okay. But one thing I saw people were ignoring is on ethics. Ethics came on like 3 days of the 8 days. And so you can't know when it's going to come. So you should be revising ethical questions. You're not really going to be taught ethics as a subject, but it's up to you to go look for these ethical scenarios and try and answer them. Okay, so we have an ethical scenario here. You're managing a busy hospital, ICU hospital, in the ICU with only 1 available bed. 3 critically ill patients need immediate admission to the intensive care. What criteria would you use to decide who gets the bed? So it's usually 5 marks. So it's you to decide. So you can't just say patient A, but you have to, as much as you're saying, yes, patient A is the one who's going to get it, but you have to give explanations. So we start. Patient A, a 40-year-old man admitted with difficulty breathing after 3 days of fever and cough. He has been diagnosed with pneumonia. His oxygen levels are critically low, but improve with oxygen therapy. He has no prior medical issues and has responded well to treatments in the past when sick. So in summary, pneumonia patient, DIB for 3 days and cough, and low oxygen. We go to patient B. 65-year-old woman, oh, by the way, this guy is 40. 65-year-old woman, long-standing history of heart disease and diabetes. She's struggling with worsening shortness of breath and low blood pressure. Despite high-dose medication, her condition is deteriorating. Her organs are showing signs of failure. She has been hospitalized multiple times in the last 6 months, and her family mentions she has been too weak to do her daily activities for the past year. In summary, 65-year-old woman, history of heart disease and diabetes, has come in with shortness of breath and low blood pressure, and she's deteriorating. Patient C, 25-year-old woman, 20 weeks gestation, who collapsed at home with seizures. She was brought in unconscious and diagnosed with severe eclampsia. Her blood pressure remains dangerously high, and there are concerns for both her and her baby. She has always been in good health before this instance and has no prior hospitalizations. Okay. Summary is patient C, 25-year-old pregnant woman, has come in with seizures, high blood pressure, and is 20 weeks gestation. So who is getting the bed? I want to see the answers. So if you are patient A, you mentioned patient A, give an answer. If it's patient B, give an answer. Patient C, give an answer and your reasoning. So, okay, I'll explain first. So when answering these questions, you just don't pick anyone based on your feelings. There are guidelines or things that will guide us on how to answer this question. Number one, we look at the medical prognosis. We have to prioritize the patient with the highest likelihood of survival with immediate intensive care. Okay? So this involves assessing the reversibility of the condition, the potential for recovery, and the overall prognosis if treated in the ICU. Okay? So in our 3 patients, so in terms of medical prognosis, we can see patient A, his condition is reversible, isn't it? I mean, if you give him oxygen therapy, his condition will be reversible. So he has a very good chance of survival. Patient B, the family has said that she's becoming too weak to do her daily activities. So this is showing that despite treatment, the prognosis is poor. And we can see that multiple organs are showing signs of failure. So even if we give her the bed, will she survive? So chances of survival are very unlikely. Patient C, she's critically ill. She has an eclampsia. So she's having a seizure and high blood pressure, but it is easily reversible. Okay. So from prognosis, we eliminate B. And then severity of illness, consider the current severity of each patient's condition. Patients who are more critically ill and would benefit most from ICU would be prioritized as long as their prognosis is favorable. So patient A is severely ill. Patient B is worse. And patient C, if we don't do anything about it, she will die. Okay? And she'll lose both her and her child. Okay? So that's how you look for severity of the illness. Okay? And then the next one is quality of life post-treatment. Evaluate the expected quality of life after treatment. Patients who are likely to regain a higher quality of life should be given preferences. So for patient A, he has a pneumonia. If we treat this pneumonia, his quality of life will be back to normal, isn't it? So we should prioritize that person. For patient B, I mean, as much as yes, we're going to treat her, we're just going to prolong her life, okay? So her quality of life will decrease. For patient C, outside from these seizures and high blood pressure she's experiencing, she's most likely going to recover and going to deliver her baby. So her quality of life will be okay. And then ethical considerations. Ethical principles such as fairness, non-discrimination, and the potential impact on dependents or society should also be considered. This includes avoiding biases based on age, gender, socioeconomic status, etc. So here, if we were to do ethical consideration, patient C would take the day because ethically, we're going to save 2 lives compared to the rest, isn't it? So she should have higher priority. Okay. And then availability of alternative care. Assess whether alternative care or intervention should be utilized for any of the patients, which might allow them to be stabilized or managed outside of the ICU, thereby prioritizing the patient with no other options. So for patient B, can she do without the ICU? Most likely. Patient A, he just needs oxygen therapy. So does he need an ICU bed? No. So you just manage with close monitoring and oxygen therapy. Patient B, it's going to be supportive. Okay, so the condition is not likely to improve with intensive treatment, okay? But for patient C, we are saving her and the baby, and there's high likelihood of survival. So that is how you're supposed to answer the question. You have to consider all these 5 factors. And yes, so in conclusion, if you were to answer, you say, I'd choose patient C because she has a high likelihood of survival. Her medical prognosis is good. Her illness is severe, but she would benefit most from the intensive care. Ethically, we are saving 2 lives, and then her quality of life post-treatment is of higher quality. Okay, and she would not do without, and she does not have an alternative care treatment. Okay, basically that's how you do it. You'll juggle up the words, but that's how it's done. He can get oxygen therapy at home even. Yes. Okay. Any question? I think I'm done.